intraocular pressure is raised above the tolerance limit of the affected eye, resulting in a damage to the optic nerve and potential visual field loss. What does mean the tolerance limit? All of us have our own tolerance intraocular pressure, and if intraocular pressure is above this limit, the glaucoma has a high risk of development. We have the statistically normal intraocular pressure, but as you understand, individual normal or tolerance intraocular pressure may differ from the average intraocular pressure. There exists a group of patients with the so-called normal tension glaucoma when they have the statistically normal intraocular pressure, but they have signs of glaucoma. On the other hand, we have a group of patients with the so-called ophthalmic hypertension. They have increased intraocular pressure, increased above the statistically normal intraocular pressure, but they have no signs of glaucoma. So in all the case of glaucoma patients, we are talking about the tolerance, individual tolerance limit of the patient's eyes. Pathophysiology of glaucoma revolves around the aqueous humor dynamics. The aqueous humor is a clear watery fluid filling the anterior and posterior chambers of the eye. I remind you that anterior chamber is a space between the posterior surface of the cornea and anterior surface of the iris and crystalline lens. Posterior chamber is the space behind the crystalline lens and in front of the vitreous body and silvery body on the lateral sides. Both chambers are connected one with other by the pupil aperture in the iris, in the center of the iris. Ciliary processes of the ciliary body is the seat of aqueous production. There exist three mechanisms of aqueous humor production: diffusion, ultrafiltration, and secretion, the so-called active transport. These mechanisms play a part in its production at different levels. Aqueous humor flows from the posterior chamber into the anterior chamber through the pupil against slight physiologic resistance. From the anterior chamber, the aqueous is drained out by two ways: trabecular outflow through the trabecular meshwork and by the uveoscleral outflow. Trabecular outflow is the main outlet for aqueous from the anterior chamber. About 90% of the total aqueous is drained out via this way. Trabecular meshwork is situated in the angle of the anterior chamber, as you can see in these slides. Next to trabecular meshwork is present the canal of Schlemm in the substance of the sclera. Aqueous humor is drained from the anterior chamber to the canal of Schlemm through the trabecular meshwork and then to the collector channels or intrascleral aqueous vessels, and then to the episcleral veins. Some endogenous factors do influence the aqueous formation. Passive mechanisms of aqueous formation are dependent on the level of blood pressure in the ciliary capillaries, the plasma osmotic pressure, and the level of intraocular pressure. The intraocular pressure refers to the pressure exerted by intraocular contents on the coats of the eyeball, usually on the fibrous coat of the eyeball. The normal IOP varies between 10 and 21 millimeters of mercury. When we use Maklakov's tonometer, which we use widely in our country, the intraocular pressure, normal intraocular pressure, varies between 18 and 25 millimeters of mercury. The following factors determine the level of intraocular pressure: rate of aqueous secretion, resistance encountered in the outflow channels, and level of episcleral venous pressure. Fluctuations of intraocular pressure occur with the time of day, heartbeat, blood pressure level, and respiration. The pattern of diurnal curves of IOP varies in the normal eye with a tendency to higher intraocular pressure in the morning and lower in the afternoon and evening, but not in all of us. There exists a group of persons in population with another pikes of intraocular pressure. At night, in the evening, in the early morning, and so on. Normal eyes have a smaller diurnal fluctuation, less than 5 millimeters of mercury, than glaucomatous eyes, in which the fluctuation may be even 10 millimeters of mercury or more. So this is one of the signs of glaucoma, increased amplitude of diurnal IOP fluctuation. But it's not the main sign, it's just one additional sign by which we can determine the presence or absence of glaucoma and control the efficacy of our therapy. So what are the basic methods of examination in case of glaucoma? Of course, visual acuity examination, which we have to check in all the patients with ophthalmopathology. And in case of glaucoma, it's not the early sign of glaucoma damage. In early stages of glaucoma, maybe no problem with the visual acuity, no loss of visual acuity. So only in advanced stage we can see decreased vision. Slit lamp examination. You know that slit lamp, it's the binocular microscope with the additional source of light in form of slit. So the name of this lamp is a slit lamp, by which we can check the anterior segment of the eye, and with the additional lenses we can examine the angle of the anterior chamber, which is very important in case of glaucoma, and even the inner structures like vitreous, retina, with specific areas of retina like optic nerve disc, like blood vessels, like yellow spot, and so on and so forth. So slit lamp examination of the anterior chamber can help us to determine the presence of dystrophic changes, which are often associated with the glaucoma development, and several other additional signs of glaucoma. One of the basic methods of glaucoma management, glaucoma testing, is the measurement of intraocular pressure. Tonometry is the name of this method, and the devices, equipment which we use for the examination are called tonometers. There exist different types of tonometry, and even here on the photos and pictures you can see the different tonometers. On the left one is the digital tonometer, the simplest way how to measure the intraocular pressure. You press with the index fingers of both eyes the eyeball through the upper eyelid, when the patient is looking down, and compare the sense of ophthalmotonus with the normal intraocular pressure. Usually during our practical classes, we train this method, and we ask because you have no such an experience, you can firstly palpate your own eye to get the sense of the normal intraocular pressure, and then palpate the patient eye, and then compare the results. Normally, if you palpate the normal eye with the normal intraocular pressure, I mean, it looks like a sense of palpation of the 5-minute egg, boiled egg. In case of increased intraocular pressure, if it's a mild increase, it will be like a palpation on the tomato, solid tomato. In case of advanced stage of glaucoma, in advanced increase of intraocular pressure, like palpation of the orange in its outer coat. And in case of acute attack of angle closure glaucoma, when the intraocular pressure maybe 60, 70 millimeters of mercury comparison with 21 normal intraocular pressure. In this case, the eye is so solid as a wood or a stone and very painful during the palpation. On the other hand, in case of traumas or other disorders, it may be a hypothony when the intraocular pressure is less than normal, and it may be rather severe depression after your palpation for several seconds or even minutes. So this is the simplest way. Of course, it's, we can't check exactly how many millimeters of mercury is patient's intraocular pressure by this method. But if you have enough experience of palpation of thousands of patients with normal and abnormal intraocular pressure, you can determine rather good the normal or abnormal intraocular pressure in particular patient. The second photo, it's a photo of Maklakov's tonometer, which we use widely in our country. And here you see on the right photo the Goldman applanation tonometry, which is the gold standard of ophthalmotonometry in most of the countries of the world. The next method of examination is ophthalmoscopy. Ophthalmoscopy is a checking of the funduscopy, examination of the fundus of the eye. In case of ophthalmoscopy, we have to check, first of all, optic nerve to determine its changes, and also surrounded retina around the optic nerve. Sometimes in advanced stage, you can see additional changes of the central part of the retina, but firstly, we have to check the optic nerve disc. Visual field examination, very useful method even in early diagnosis of glaucoma. There exist different types of perimetry method of examination of the visual field. So there exist different types of perimetry: kinetic, static, automated perimetry, compimetry as a method of examination of the central part of the visual field. Combination of this method can help us to determine not only the presence or absence of glaucoma, but also the stage of the process and control the efficacy of our treatment during the follow-up period. Gonioscopy. Gonios means angle, so gonioscopy means examination of the angle of the anterior chamber. Technique of biomicroscopic examination of the angle of the anterior chamber with the help of special lenses is called gonioscopy. We usually use local anesthesia, put the lens, special lens with 3 or 4 mirrors on the surface of the patient eye, and with the help of these lenses, we can examine the angle of the anterior chamber to determine is it open angle, and in this case it will be open angle glaucoma, or angle is closed and the name of the glaucoma in case of closed angle is angle closure glaucoma. There exist some other changes of the angle of the anterior chamber, like formation of synechias, adhesions in the angle of the anterior chamber, growth of new blood vessels, abnormal blood vessels, the so-called neovascularization of the angle. So there exist different specific features which we can find during the gonioscopy. Tomography, it's a non-invasive technique for determining the facility of aqueous outflow. In most of cases of glaucoma, we can see resistance to aqueous humor outflow, but in some cases, the glaucoma is the result of the hypersecretion of the aqueous humor. So to determine the problems with the aqueous outflow, we perform the tomography tests. Several words about the tonometry. The IOP is measured with the help of an instrument called tonometer, and 2 basic types of tonometers available are indentation, Schwartz tonometer, and applanation tonometers, like Goldman's, like Maklakov's tonometers. A rough estimate of IOP can be made by digital tonometry, which we have already discussed. Special provocative tests exist for the diagnosis of glaucoma, such as water drinking test, bulbar pressure test, dark room test, and others. What is the principle of these provocative tests? In case of doubtful signs of glaucoma, we can perform these tests. We measure the intraocular pressure before and after the test. For example, in the water drinking test, we measure the intraocular pressure of our patient with the doubtful signs of glaucoma when we are not sure is it glaucoma or just ophthalmic hypertension or just a it looks like glaucoma, but no real glaucoma. So we measure the intraocular pressure before the test, then we ask the patient to drink about 1 liter of water, and in 20-30 minutes after drinking of water, we measure the intraocular pressure again. So what's the difference in reaction of normal patient and patient with glaucoma? In case of normal patient, after water drinking test, the intraocular pressure usually increases for on 2-3 millimeters of mercury, not more. In case of glaucoma, the amplitude of fluctuation before and after the test may be 5 millimeters of mercury or even more. The same situation with the darkroom tests, especially in case of angle closure glaucoma, because in darkness the pupil becomes white and the iris, root of iris, can partially close the angle of the anterior chamber. The intraocular pressure also increases. In case of positive provocative tests, the amplitude of fluctuation of intraocular pressure on the test background is more than 5 millimeters of mercury. So if you got the difference in results before and after test more than 5 millimeters, you can suggest that such patient has signs of glaucoma. Here is the description of one of the tests for the water drinking test. So to measure the rise in IOP after drinking, or 1 liter of water is necessary, and 15, maybe 20 minutes. Sometimes if we are not sure, we can measure it every 15, every 20 minutes for several hours. A rise of here of 8 millimeters of mercury or more is diagnostic. Now there exists a suggestion that even 5-6 millimeters of increase of intraocular pressure is also rather reliable sign. Several medical tests with several drugs and tomography are also useful in case of glaucoma patients examination. There are three main types of glaucoma: congenital, primary, and secondary, due to the different disorders of the eye or systemic disorders. For example, secondary glaucoma may be due to the vascular disorders, it may be medical glaucoma due to the use of, for example, prolonged use of corticosteroids, not only local but systemic therapy of steroids, which is widely used in case of some rheumatic disorders, other systemic pathology. In this case, after several years of corticosteroids use, some patients have developed the glaucoma, signs of glaucoma. This is the secondary glaucoma. Glaucoma may be after the traumas, post-traumatic glaucoma, as a result of the development of the tumors inside the eyeball, and so on and so forth. If you remember one of our previous lectures and talk about the intraocular tumors like melanoma or retinoblastoma in young persons, the second stage of tumor development is associated with an increased intraocular pressure with a secondary neoplastic glaucoma due to the formation of tumor inside the eyeball. What are the main signs of glaucoma? Raised IOP, raised intraocular pressure. Here you see that in brackets more than 21 millimeters of mercury, but don't forget that there exists a group of patients who has the individual norma of intraocular pressure less than the most in our population. And for them, it's possible to put the diagnosis of glaucoma even if the intraocular pressure during tonometry not more than the superior border of the statistically normal intraocular pressure. So patient with intraocular pressure 19 also may have glaucoma if his individual norma is very, very small. So in this case, two basic diagnostic tests are necessary, and on the basis of these changes we can put the diagnosis of glaucoma. I mean glaucomatous optic nerve damage and glaucomatous visual field defects. If we can see both, this is the signs of glaucoma. So let's discuss in details the changes of the optic nerve and the visual field. Optic nerve disc changes in glaucoma. In the center of the optic nerve, in all of us, there exists a cup. The optic cup is a pale depression in the center of the optic nerve disc, which is not occupied by neural disc tissue. Glaucoma causes a progressive loss of the retinal nerve fibers. So the glaucoma changes of the optic nerve are pallar area or disc, and in advanced stage, optic disc appears white and deeply excavated. Glaucomatous optic atrophy. Marked cupping excavation may even reach the disc margin. So here you see the patient with the thinning of neuroretinal rim on the periphery of the optic nerve disc and enlargement of the optic disc cup. And you see the color of this part of the optic nerve disc is grayish, pale. So this is the enlarged glaucomatous optic nerve cup. Glaucomatous visual field defects include bearing of blind spot. If you remember, blind spot, it's a scotoma on the blank visual field physiological scotoma due to the presence of the optic nerve disc on our retina, because in the area of the optic nerve disc, there are only nerve fibers and no cones, no rods, no photoreceptors. So all of us have such a scotoma, but it's very small, about several degrees in the thickness of this scotoma. So there are no changes of the optic of the visual field, and no complaints, of course, because our brain suppressed the image of this scotoma. But in glaucoma patients, there exists an enlargement of the blind spot. We can also find the presence of the paracentral scotoma, arcuate or B-room scotoma. Isoptocontraction means constriction of the visual field, and peripheral nasal step. Look at these photos. Look how is the patient with glaucoma in different stages see the surrounded world. So the normal vision, rather wide visual field. Patient in early stage of glaucoma, you see the peripheral constriction of the peripheral visual field in these angles. So it sometimes may be dangerous for the patient because he can't see. But in this stage, patient may have no complaints because it's very difficult to determine without perimetry, special examination, the presence of this constriction. In this stage, in advanced stage, of course, the patient has a problem and has a complaint of the constricted visual field due to the presence of only central part of the visual field. You see no periphery. For such a patient, it's dangerous to cross the road because it's necessary for him to turn his head all the time because he can't see with his peripheral vision any object and so on. And you see a sort of tubular vision in extreme, in very advanced stage of glaucoma, when there is only a central small island of the visual field. You may compare one more scheme of the patients with glaucoma with start with the normal visual field and this picture number 6, only small island somewhere on the periphery of the visual field. Such patient, he's not totally blind because through this very small area he can see something, but his vision is very poor and his visual field is closer to zero. So without treatment, we can see such a clinical picture as a progress of visual field loss with the years, sometimes in case of aggressive signs of aggressive types of glaucoma, even month from the very beginning to the final end. Here you see the blank of visual field, and you see also a patient in different stages. As you understand, these black areas, areas where patient can't see any object, grayish areas of depression of the visual field. Patient can see bright object but can't see the dim object, and no, white and whitish areas, it's area of normal vision. And you may compare patient in early stage and in advanced stage with a lot of scotomas, absolute scotomas, or relative scotomas. So these are the basic changes of the visual field during the glaucoma. In advanced cases, the visual field loss gradually spreads centrally as well as peripherally, and eventually only a small island of central vision is left. In stage of absolute glaucoma, there are no visual functions. It may be just a sort of light perception with the wrong light projection. It means that the patient can recognize presence or absence of light, can differentiate between day and night, but can't say exactly where is the light. He can't determine the direction of light. Or it may be zero. I mean the total blindness. Glaucoma is one of the main causes of blindness, irreversible blindness in the world. among all the disorders in adults. We can just stop the progress and keep the visual functions for a long period of time, but unfortunately we can't recover the visual functions. So if you'll get such a patient in advanced stage, you can just stop the progress and save the small island of the visual field, but you can't hope, and the patient can't hope for the recovery and for the widening of his visual field. Unfortunately, it's an irreversible reversible loss of visual function. So the best way to help the patient is early diagnosis. We have no measures for the prophylaxis of glaucoma, not only formation of risk groups among those who have relatives with glaucoma, who use specific drugs like corticosteroids or several others, but unfortunately there are no effective prophylactic measures. So only early diagnosis can help us to start our treatment immediately and to stop the progress or decrease the rate of progression of glaucoma. One more patient, one more example of correlation between the optic disc changes and visual field parameters. Here you see the scheme of the optic nerve disc picture. You can see the photo of the patient in the same stage, real photo of the real patient, and visual field of the same patient. So early stage of glaucoma, small enlargement of the optic disc cup, you see it's on the photo, and relative scotomas in the central part of the visual field with the normal periphery. Second stage, you see, you may compare the optic cup, this pale central part, you see enlargement in comparison with the previous stage, the same situation on the photo, and you see arcuate scotoma, this black scotoma inside the normal visual field, and partial constriction of the visual field in some meridians, usually from the nasal, superior nasal side. Advanced stage of glaucoma, you see that it's a very wide cup, pale or grayish disc, and you see absence of more than half of the visual field due to the constriction of the visual field in more than one meridian. And the final stage, when the patient's vision is zero, or no, in this case not zero, because we can determine several islands, small islands of visual field. It means that patient can see something through this very, very small, like through the hole, yes. But you see that totally pale optic nerve disc with a very large optic cup equal to the size of the diameter of the optic nerve disc. Of course, in this case, even surgery can't help usually to stop the progress, and unfortunately in several years or months we have a totally blind patient, disabled person. So this is not only medical but also social problem. Several words about congenital glaucoma. The congenital glaucomas are a group of disorders in which abnormally high intraocular pressure results due to developmental anomalies of the angle of the anterior chamber, obstructing the drainage of aqueous humor. About half of cases of congenital glaucoma manifest within first year of newborn's life, the so-called infantile glaucoma. And in some cases, the onset may be delayed up to 3 to 16 years of life, the so-called juvenile glaucoma. Sometimes it is associated with other congenital anomalies. What are the clinical features of congenital glaucoma? Photophobia, blepharospasm, lacrimation, and eye rubbing often occur together. Corneal signs during the examination of cornea with a slit lamp, for example. Corneal edema. It is frequently the first sign which arouses suspicion. And corneal enlargement. Normal infant cornea measure 10 millimeters. A diameter of more than 13 millimeters confirm enlargement.